It's a specialty that I can guarantee you nobody else is going to touch. When it comes to the eyes, no other department interferes. That is the first and the foremost thing. We do have wet labs. We practice it on various things. We have foam. We practice it on banana peels, watermelon peels. AI or even robotics, for that matter, can never replace a human hand. It's a bit difficult to start individual private practice if you're a first generation doctor like my own self. The first surgery of the world, a cataract surgery, was done by our own surgeon, Sushruta. I ended up operating 11 patients from that old age home after a trend going on known as the iPad baby syndrome. A kid
Okay.
doesn't eat, you give them iPad, they eat immediately. So that is, people say radiologists have the highest amount of investment. But you see in ophthalmology, the amount of investment is way too much. But ultimately, everyone, me, you, everyone is going to develop cataract.
Hey guys, welcome back to our show. Today we have Dr. Ayush, who is an ophthalmologist. Hey, Dr. Ayush.
Hi, Dr. Kanchan. How are you?
I'm good. Thank you for coming to our show
Thank you so
amidst
much for
your
having me.
busy schedule.
No. Thank you so much for having me.
Can you introduce yourself briefly to our audience?
Yeah, so my name is Dr. Ayush Sharma. I'm an MS ophthalmologist here in Goa Medical College. Right now, employed as a senior resident here. Uh, I completed my MBBS from JJ Medical College, same as Dr. Kanchan, and that's how I know her. And nothing much. I've been a part of a lot of other uh, things in my college time, different social interaction, lot of activities and what all. So non-academic part is full of things. I mean, and academically, as of now, I'm employed here at GMC. This is a medical government medical college set up in here in Goa, the only medical college of the state. And yeah, that's all about me.
Like in India, residency is very tough, Dr. Ayush. How did you manage to do all these non-academic stuff? How did you plan
Well,
your time?
I would say yes, it is a bit difficult. It's very laborious. It requires utmost attention, and ophthalmology being a microsurgery department where
Hmm.
we operate our most of the surgeries under the microscope with the learning curve that is very steep and everything. Of course, we need to put in a lot of hours, but eventually things do get a bit calmer and better as you get more experience and everything. And like I said, it's the sole medical college of the state. So, of course, the patient load was too much, but that is the only thing
Okay.
that a resident should think of. So, nevertheless, I never gave up on my hobbies, you would say. Like, I have often been a part of a lot of music gigs and DJ performances. So, I used to DJ as well at times. And I've been composing a few songs, using the apps and everything. So, I keep trying here and there. And since I've moved to Goa from the past 4 years, I often go and have and play some sea sports like I'm starting to learn how to surf. I'm also trying to learn other water sports like underwater rugby. Then I've also had a lot of
Wow.
fun experiences kayaking as well. So yeah, I mean, Goa has been really good for me, both residency and outside my residency life as well. So I do agree that the residency in the first year specifically is very tough. But as you get a grasp of things, the responsibilities are more about taking up major decisions and whatever, and then the things just grows on to you.
That's quite interesting. A very different approach to life, how to escape all this rat
Yeah.
race. So, you mentioned one thing which caught my attention. You said the learning curve is steep. So, how does your branch differentiate from the other surgical branches? If you want
Well,
to put some light.
I mean, yes, definitely ophthalmology is an end branch. By end branch, I mean it's a specialty that I can guarantee you nobody else is going to touch. When it comes to the eyes, no other department interferes. That is the first and the foremost thing. And secondly, when I say an end branch, a lot of our ophthalmology post graduation, we have fellowships. We don't have some MCH course or anything as of yet. There are few MCH courses in AIMS and in another some at Central Institute of 3 years, but of my opinion and my knowledge, ophthalmology really doesn't require a 3 year course. Most of the fellowship course
Mm-hmm.
over the years, which used to be of just 1 year, expanded to 1.5, 2 years now, even. So I guess, and these fellowship programs are all personal, institutional, or it could be even NBA accredited to many of the eye institutes
Like
such as
what kind
Shankar
of fellowship
Naik.
program?
Yeah, so I mean, like it's all institution, corporate, medical colleges. They are all variable, but just to categorize them. So we have VR fellowship, it is retina fellowship. Then we have phaco-refractive, glaucoma, squint, pediatric ophthalmology, oculoplasty. There's a lot, cornea as such. So the fellowship options are various, although they're very difficult to get into in few of the programs, but the rest of the programs are very easy. So I mean, every specialty at one point of time is going to have super specialties. Like nobody wants to go to a general physician anymore. If you have diabetes, everybody prefers an endocrinologist. So that's the same state in every branch now. So this was one thing that I feel was a bit different from other branches, that we didn't have MCH back in those days, and neither it is required to have a huge 3 years course. And in a lot of tier 2, tier 3 cities, once you are well versed with basics of ophthalmology, like running an OPD, diagnosing, and such as operating cataract, which is our bread and butter basically, it's very easy to even settle as a general ophthalmologist,
Mm.
in my opinion. So you don't really need a lot of
So
preparation.
in the beginning, so you took up this by your own choice, or you had to like settle for this branch, or what was your thought process?
Well, in my mind, I really wanted to take general surgery or anything that has to do with surgery. I
Okay.
was clear cut. By internship, I was sure that I don't want to do a certain job. And
You
then
wanted to hold a scalpel always.
yes, 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 forever, I would say. Now, ortho, general surgery, or OBG, that is gynec,
Hmm.
these three major surgeries, like how we could not call them the big five. So I did not want to burden myself with a lot of working hours. I mean, in comparison to ophthalmology, they work almost the double the time. I mean, I don't know how they find out so
Okay.
much of time in 24 hours. As in, they work for 48 hours in 24 hours. But ophthalmology, in my opinion, has always been this very clean, neat, good surgery and a good medicine with a good work-life balance kind of a department. Also, I preferred it more than ENT for the same thing, that I also had developed an interest in ophthalmology back in my internship as well, because I really love the way that it's so broad. I mean, you could be checking out the refractive errors at one end, and then the other day, next day, you would be operating cataract surgeries. You'd be doing a lot of retina surgeries, a lot of procedures, and the finesse of it is all microscopic and training. So a lot of people are afraid of
Any
microscope, use of
inspiration for
microscope.
you?
Sorry?
Any inspiration for you to take up this branch?
As in, I do not have one idol figure, but a lot of interaction with my residents helped me. I just used to see how their
Okay.
lives are. And plus, most importantly, is to see if they are smiling or not. Ophthalmologists always smile.
So there is no toxicity in your branch? You mean to say that?
I mean, the toxicity is a very ambiguous word, I would say. Some people who are not used to a lot of hectic work schedule, especially when they have not done a lot of procedures and work in their internship, might find
Hmm.
any of the branches for that matter very toxic, like how they usually say. Plus, it also depends a
Hmm.
lot on what institute you get into. Luckily, I have been a part of an institute that has never been toxic in other ways. Like there is the department, the consultants, the seniors, the juniors, they all work in harmony. They just, do what they're supposed to do. There is no unnecessary harassment or any of that sort. There is no outsider insider
You
thing.
seem to
Nothing,
be a
nothing.
very you seem to be a very ideal senior for your juniors, Dr. Ayush.
I mean, that is for my juniors to answer because I think like see, this is all very personal and interrelationship, I would say. You can't be too
Hmm.
careless in ophthalmology. So had I been very lousy
Yeah.
and not very attention paying, as in the eyes never forgive, like how they say in my this thing, the eyes never forgive. And I'm not trying to draw any other comparisons because obviously I know I would like to preach for my subject of field. But for example, when you're operating on a hernia in an open abdomen surgery, the patient never knows what's happening to him because there isn't full anesthesia, and you have a lot of you have a big operating space, and you have like a lot of space to operate and a lot of margin for error and risk is there. And next day the patient is only going to complain of some abdominal pain because of the surgery. But in the eye,
Mhm.
it's that moment, a millimeter here and there, your case gets complicated, and the worst part is the patient will know it the moment you take off the eye patch for surgery. So
Oh my
you
God.
cannot
Yes,
lie, and a patient is immediately going to tell,
exactly.
"Oh, my doctor did a great job," or "My doctor did not do a great job." So that
I
way,
mean,
the error of
there are
margin.
no revision surgery in your field.
No, no, as in, it's not like they'll just give you a scalpel blade and ask you to just go operate directly. We do have wet labs. We practice it on various things. We have foam. We practice it on banana peels, watermelon peels. First we use inanimate objects and
Oh, a
vegetables and fruits.
simulation lab.
Yeah, and then to have even more realistic approach, we do it on goat eyes or bullseye that is available in the market.
Oh wow.
Yeah, so these are a part of our wet lab,
That
and once we have gained sufficient amount of uh, confidence and the trainer is more confident, then we go stepwise. When we prepare, pre-operative preparation of the patient takes a whole lot of while. You must know whom to operate, and as a surgeon you must know whom not to operate, because obviously it's very important to have all those checklists, check all those points. And once you clear past that, we are allowed to pose our own cases, or we are allowed to operate on our this thing on our seniors cases where they give us a few steps. We observe those cases for a long time, different cases. So it's a very gradual process, and it can never be I'll shoving up a scalpel blade in a resident's hand and asking to operate, because first of all it is very unethical. So I feel that is why I said this is a very tedious process. It takes a long learning curve as compared to this thing. You need to get adjusted to the microscope. You need to get adjusted to the patient. You need to get adjusted to the sitting. It's a sitting surgery, by the way. So another difference
okay.
from other
So you
other.
have so yes, so we can draw parallels where anesthesia and ophthalmologists
Oh
like
yeah,
the
yeah,
chair and the
definitely.
OT.
Yeah, I mean
So,
we need two chairs.
Dr. Ayush, is there any case, do you remember any case which challenged you emotionally, mentally, physically during your residency?
Uh, I mean, there have been multiple instances. For example, just out of my own personal interest and my this thing, I was very closely associated to a old age home, and
Oh,
yeah, so it's known as Amazing Grace Old Age Home, and I happened to come across two of the ladies, and the accompanying was a sister, as in like the church Wali sisters, who used to run the whole thing. And then she got me these two ladies, and in our OPD, I examined them and everything, and then I prepared. And then I also happened to speak to my patients a lot because a lot of them are of geriatric age group. And then they told me their whole
okay.
story and everything. They belong to an old age home. There are many such ladies like that. Eventually, I got so invested emotionally and connected. I just felt so connected to them. I felt like I was speaking to my own grandparents. And I ended up operating 11 patients from that old age home after I
Oh,
examined
wow.
about 25.
Congratulations.
Yeah, and I had and as in operating on them was not just a surgical experience for me. It was more of a gratification. It was more of you know, it felt so good that I could make a change, mark something in someone's life, that now they're able to see better and feel better because of me. And having said that, one fine day they all come for post-operative follow-up day and they give me a mug. So that mug has all those
So
11
wholesome.
ladies who, yeah, all those 11 ladies who I had operated on, and they say, it says, thank you, Dr. Ayush. And even today, that cup lies in front of my cabinet in my home. My MBBS degree,
That'll
PG
be
degree is
very
all behind.
priceless.
Yes, that is very priceless.
Exactly.
It's placed right in the front. So things like this make me always wonder, like, uh, I'm very glad that my surgical skills and experience can add such value to people's life. Old age home is anyway emotionally very daunting, because you cannot, deal
I
with the fact
can
that
understand.
the old age patients do not deserve to be at an old age home in the first place, but that's the sad reality of this world. So at least I could do
And
my part.
plus, it is surgically challenging for you because operating on geriatric age group is not easy. The
But
non-medicos will not relate to
I
it,
have been
but
trained
every
this way now.
medico will.
Yeah, but I've been
Oh,
trained this way
nice.
because that is my patient age group. Of course, we do get a lot of pediatric patients as well, but they mostly lie in the area of squint and refractive error correction wala part.
Okay.
Very rarely we come across congenital or developmental cataract, but yeah, we do operate on kids as well, and that's when we need help of anesthetic, because otherwise all are under a local anesthesia.
Nora. So, also, everyone has this one doubt in all these non medico groups or in all my families and distant friends and everyone. They often impose this question that how often should we get our eyes checked to, avoid these whatever changes naturally happen in the eye, which we'll talk about it later. There are some
Mhm.
changes which will happen, unavoidable changes, but how often should a normal adult get their eyes checked?
As in, I would like to answer your question by again dividing the whole population into pediatric, adolescent, young adults, old adults, and very old age. Now, pediatric
Mm-hmm.
age group is something that requires the most amount of attention, is because kids lie. And sometimes they lie
Mm-hmm.
for their own good, and sometimes they lie so as to not get beaten up by their parents. Now, when they say that I can't see the blackboard properly, the mother knows that the kid is lying and they don't want to go to the school. But thankfully, I've noticed that a lot of school and government programs which have all these very frequent annual eye checkup examination, they bring us a lot of
Mm-hmm.
young kids, and all these kids do end up having some form of refractive error in the end. And the ones who are not attended to, they end up having some form of squint, or they end up
Okay.
developing amblyopia right from the childhood, as it is known
Mm-hmm.
as lazy eye. So, regarding that, yes, the pediatric age group and specifically young children who have just entered
Mm-hmm.
school, I would recommend that annual examination in the school in itself, or whenever the child complains, is the ideal time.
Okay.
Adolescents,
Good.
however, they have a lot of screen time, they have a lot of
Mm-hmm.
mobile use, a lot of tab. They go out to the movies and everything. So I
So,
wouldn't
what is
exactly
the
call,
safe time? Do you people advise that this is a safe time for screen time or anything like that?
amongst all the
Is there?
studies that I've, yeah, I mean, of all the studies that I've gone through, it always says as less as possible. Now, that is in an ideal most situation that you would say. The children under 1 year of age, 1.5, absolutely no screen time for them. And
Okay.
only under 5 years of age, I would say roughly they can have any as in they could have a long distance vision like maybe TVs or television, avoid close distance object like mobiles and tablets. That is also
Okay.
because of the fact that their eyes are still hypermetropic. By the age of
Mm-hmm.
7 and 8 is only when they achieve the full range of vision. So we need to subject such kids to long distance interactive screen time. So TV and all, yes, it's possible, but not more than half an hour or 1 hour.
Okay.
Like we see these days, there is a new trend going on known as the iPad baby syndrome. A kid
Okay.
doesn't eat, you give them iPad, they eat immediately. So that is all at all a very different concept of how it's not healthy psychologically and for the brain development. But eye-wise,
Mm-hmm.
yes, it do have an impact. A lot of kids are that turning to be myopes these days,
Okay.
and that onset of myopia has also increased with increased screen time in such kids.
Mm-hmm.
Now, there's a lot of pathological and a lot of anatomical variations also. Genetically, also a lot of myopes are present, but myopia with excessive use of accommodative muscles causes the stretching of the eyeball in such young kids
Okay.
because they have very strong accommodation. So, which adds up to the myopia.
Okay.
So, for the such pediatric age group, I would always recommend as minimum as possible. I know it's not possible, and we just cannot state out textbook facts for that matter because
Because
we
this
know
is
it's
the
not
digital
practical.
era.
Yeah, yeah, it's not at all practical. I mean, I myself have a lot of screen time that days, but how can I go and advise other people about that? And again, coming to young adults and adults, unless you're under 40 years of age and you come to the category of normal adults, like no comorbidities, absolutely well functioning things, no color contrast differences, then once in 5 years will suffice. But once you cross 40, annual
Mm-hmm.
eye checkup is advisable because that's when you develop presbyopia. That is the difficulty in accommodating to near objects and vision. Oftenly told as we can't read newspapers or females, they come with difficulty in putting thread in the needle, difficulty in stitching, or all that sort. So
Okay.
this is how I would group it into ages. But screen time, I would say make it as minimum as possible. There is no
But
good
that was a
that,
quite nice bird's eye view for the entire routine checkup. So,
yeah,
in
yeah,
the beginning, you also emphasized that you work in government college, government medical
yes.
college, right? So, how different is the practice in government medical colleges, private and corporate?
As in, it's not very difficult in terms of what procedures we do, not very different in terms of what activities and surgeries are planned. Of course, we have excessive amount of crowd, which you would not find in private, and that automatically brings
Okay.
down the interactive time that you have with the patient. With in corporate
Mm-hmm.
setup, when it comes to the eye, a patient is only healed 50% once you completely listen to their problem. So if you don't listen to their problem
Is it?
completely,
Okay.
irrespective of how good you give them an advice or whatever good treatment you write them, they're never going to be happy. So there is one part of ophthalmology there as well. And then of course in government setup, the use of machines are way too more repetitive than what happens in corporate. Now, I would like to tell you that ophthalmology is not at all a very easy setup to begin with. People say radiologists have the
Mm-hmm.
highest amount of investment, but you see in ophthalmology, the amount of investment is way too much. Right from all your speculums, your trial frame set, the small glasses that you use, the refraction set, the charts, Snell's or color vision, contrast
Mm-hmm.
vision, every single thing has to be purchased. Then you have the examining
And
slit
not to
lamp
forget
machine.
machine and everything if you ask backup from anesthesia.
Yeah, yeah, yeah. I mean, I have not even reached to the OT till now because this is still an OPD setup. A slit lamp machine, an HFA, OCT machine, so many machines. And these machines, some machines range around 4 crores, 5 crores, some machines 8 lakh, 18 lakh, 5 lakhs. So they do not come cheap. And of course, government can't keep procuring them at that rapid pace as a private setup or a corporate institute can.
How
Uh,
how
so
feasible is it to have an individual practice of your own in India?
if you are loaded, then there's no problem at all. Because we are
You.
very much technologically dependent. We are very much dependent on all the machines that we use for our pre-operative analysis or diagnosis, also for that matter of fact. And like how they say for MD medicine, like all you need is a table, a steth, and a pen. That doesn't work at all in
Okay.
ophthalmology. You need an assistant, you need an optometrist, you need a Snell's chart, you need a pre-operative room, you need a post-operative room. The amount of hygiene that has to be created in the OT, after OT, everything is very demanding, and they are very difficult to operate also. And for an individual, I would say if they have a lot of backup, like they come from a family of ophthalmologists or they have come from a family of other doctors who can invest so much, it's a bit difficult to
Mm-hmm.
start individual private practice if you're a first generation doctor like my own self. So I can only speak for
Okay.
myself. So I do not plan to have
Mm-hmm.
my own private practice or anything, at least for the next 5 to 10 years down the line.
That's quite interesting. Also, you can see that artificial intelligence is creeping into every branch. Do you see it invading your branch as well in the long run?
Not just my branch, I would say AI or even robotics for that matter can never replace a human hand.
Mm-hmm.
In ophthalmology per
Mm-hmm.
se, AI had jumped in long back ago, even before AI was even existed in the normal conversations. And
How?
robotics, so AI or artificial intelligence in itself helps you in procuring or gathering enough data for comprehending of whatever inputs that you give. So all the machines that we use do get calibrated with that technology in their own this thing. Like Zeiss is a
Mm-hmm.
pioneer in our field. They have amazing machines
Mm-hmm.
which can help accommodate a lot of new technologies, wavefront technology, eye tracker, movement, and everything in the microscope, in the slit lamp, in the machines that we use. So, of course, a form of artificial intelligence and automation has always been a part of our ophthalmology. Now, robotics have started in, and robotics doesn't replace a human being. It just assists to give you
Indeed.
uh, minimal amount of side effect, or it cut down on the risk so much, and it assists basically. Because obviously, we do not need an assistant here in ophthalmology. You're an only operating surgeon. Once you're under the microscope, it's not like you have two, three people jumping over you and trying to do anything from outside. So it's just
The
you.
one man
So
show.
the yes, yes. So I feel AI and robot is the next big thing in every field, and when it comes to ophthalmology, it's only going to bring better and positive outcome. But the only shortcome of this will be that this technology to be incorporated into government setups will take very, very long time. So here the corporate setups and
Okay.
the big people who can afford such machine, because they're going to be very costly, can only come forward with this technology.
So the
But
only
otherwise,
drawback is financial.
yes, 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 definitely financial, and also a person who can afford the most is also always going to keep that system with him or her, or that the that environment restricted to them so that they can offer better. So there is always going to be competitive market and a business aspect to this as well.
That is really a very crisp answer. So, you know that cataract is very prevalent in India. You think
Yes, yes.
surgery is the definitive treatment, the final answer? That's it?
Yeah, I mean, uh, I could give a small example. So if you turn your phone on the backside and you have that glass of your camera, once you have a one or two
Mm-hmm.
small scratches, you wouldn't mind. But once it gets too blurry, you do have to clean that. And once it's beyond cleaning, you have to get it replaced. Similar is the cataract. It's an
Yes.
opacification of a natural occurring lens, which is inside your eye. Of
Mhm.
course, there are a lot of medications, a lot of eye drops that do exist to delay the progression. But ultimately, everyone,
Mhm.
me, you, everyone is going to develop cataract. And there are a lot of risk factors, diet, your comorbidities like diabetes, and a lot of UV rays exposure. There are so many theories as to why cataract develops. So I guess it will happen, and there is no other treatment other than a surgery for cataract. As in all those quacks who can guarantee that with some special herbal solution from the foothills of Himalayas that they can cure cataract. These are all false. Uh, these things. The surgery is the only answer. And to your, I mean, like, to our all surprise, the first surgery of the world, a cataract surgery, was done by our own surgeon, Sushruta, who had his own technique of
Oh, yes.
taking out the cataract and then replacing it with, later it got replaced with glasses, and only later in the future we started implanting lenses. So previously, when the age used to come and the eyes used to turn white, like they used to say, they used to remove the cataract and then they used to put the patient on prismatic glasses. It was only over the course of refinement of surgery when they realized that when you remove the cataract, you can put a lens in there as well if you preserve the structures properly. So that's how the evolution of cataract and surgery has come forward. And now cataract is not just another cataract surgery, it's also a refractive surgery. It gets rid of all the astigmatic cylindrical power that you have. It gets rid of presbyopia also. Now you have a lot of new refractive procedures with lens, without lens, or a pure refractive surgery to get rid of your presbyopia after the age of 40 as well. So ophthalmology is developing in a lot of ways, in a lot of areas. And I can't even cover all of that in this podcast because that's very exciting to me, but I'm pretty much sure you must be getting bored.
But your way of busting all the myths and how you use the camera lens as an analogy to explain our lens, I think all the non-medicos will understand, and it is
Yeah.
quite interesting. So before ending this podcast, would you like to give any advice to your juniors and peers?
Uh, Please take ophthalmology, I would say. I mean, I would never advocate ophthalmology to somebody who has tremors in their hands, like physiological tremors, or could be pathological because of some disease if they have. I would also not advocate it to people who are very anxious in that matter because of the reason, because the scope of error in the surgery is very less. Till the time you're in medical college,
Okay.
till the time you're associated to an institute, a error here and there might be okay. But once you're out there in the open, everybody is going to respect a trend that you would have in your surgeries. So you must be able to take up all that pressure, leave it outside the operation theater, come to the OT and operate with everything that you have. You can't bring stress on the table. You can't be thinking about 10 different things. So it's also like sort of a meditation. So I feel people who have trouble doing that and people who cannot differentiate, their work from home from work, likewise, that is going to be very difficult for you because the error of margin, like I said, is very less. Also, I feel other aspect of it is it's a very gratifying surgery when the patient thanks you the next day. "Okay, thank you for suddenly giving me a vision." That thrill is something that I live for. The gratuity from the patient and the gratification from the surgery is almost immediate. So that part is
Yes.
always an incentive and also drives you to do better. And I feel there is always scope for a lot of things. If you have an interest in this field, do not limit yourself saying that this field is saturated. I mean, which field is not saturated? If you are sitting in one tier one city, you would notice that there are four ophthalmologists in one same lane. Nobody's asking you to open your clinic there. Move to a tier two city, move to a tier three city, try exploring the rural healthcare system. We really need more and more doctors there. And I can guarantee you, with the population of 1.4 billion people in this country, we are never going to run out of patients, or you are never going to have enough doctors for that matter of fact. So it's all about where do you want to settle, where do you think that you could do well, thinking about the future fellowship programs or whatever. And had I been an orthopedician, I would have told you a version of orthopedics in that way. Had I been an anesthetist, I would have told you a version of that. So every branch is unique, every branch has its pros and cons. I choose to just see to the pros, limit the cons, but you can never have no cons. That is there. You have to struggle, you
Definitely.
have to put in your hard work where you have to, there is no escape from that. So I feel if anybody actually passionately feels that they need such kind of a life. Plus, you'll have a good work-life balance because we do have emergencies, we do have open globe injuries, we do have a lot of perforations and everything, but it's not always that you get. Could be once a week, depends where you live. So that way you have a pretty dynamic life, and then of course you'll have time for your all hobbies like how I got time for myself. So those small perks and incentives always work.
Thank you for this informative and inspiring podcast, Dr. Ayush.
Thank you so much for having me.